So we have already done one video on oesphageal varices. So this is the continuation of the same station, oesphageal varices 2. So what is Sengstaken Blackmore tube? So double balloon tamponade tube. You can see in this picture, this is the tube. So this has usually it has 3 ports: port for gastric balloon, port for oesophageal balloon, port for gastric suction, but the modern has one extra port for oesophageal suction as well. So the standard is this, and this is also an added advantage. So there is a balloon, and there is suction for gastric. So we will describe this further. Modification: oesophageal suction port to help suction of esophageal contents, Minnesota tube, Sengstaken Blackmore tube 3 lumen. Okay, is replaced by Minnesota tube 4 lumen. So this 3-way or 3-port is this Sengstaken Blackmore tube, and when the 4th one is added, the 4th port for esophageal suction, this will be called Minnesota tube, as allows aspiration of both gastric and esophageal contents. So not just the gastric contents. So if there is no modification, insert NG tube. If you don't have the Minnesota tube, so you can put NG by yourself at the 3 ports you have in the Sengstaken tube. Indication for this: so acute life-threatening bleeding from esophageal or gastric varices, as we discussed in the previous video, that you first go for pharmacological therapy, give him terlipressin, beta blockers, and octreotide, and then if it's not working, then go for upper GI endoscopy, sclerotherapy, bending or clipping, and if still you can go for 6 sessions for bending. So if it's not working, then you go for this Sengstaken tube. So that does not acute life-threatening bleeding from esophageal or gastric varices that does not respond to medical therapy, including endoscopic hemostasis and vasoconstricting therapy, when endoscopic hemostasis and vasoconstricting therapy are not unavailable. So you directly go for this tube. So what are the contraindication? So if there is recent surgery done on esophagus or chest or abdominal surgery or strictures, so you will have to avoid it. So what are the complications of this tube? Aspiration: pneumonia can occur, failure and necrosis due to over-inflation of the tube, necrosis of the esophagus or gastric mucosa. So perforation can occur, bleeding can occur. Can you describe the insertion of technique? So yes, we will discuss this. Position the patient and elevate the head of the bed up to 45 degrees. Anesthetize the posterior pharynx and nostril with topical anesthetic. Coat the balloons with lubricating jelly to pass easily. Pass the tube from the nostril to at least 50 centimeter mark. There is a mark on the tube. Suction from the gastric and esophageal ports to clear the esophagus and gastrium. When the gastric balloon is correctly positioned in the stomach, inflate the balloon up to 500 ml of air and clamp the pot. Pull the tube back until resistance is felt against the diaphragm. Inflate the esophageal balloon by the sphygmomanometer to 30 to 45 mm of Hg and clamp the port. When bleeding is controlled, reduce the esophageal balloon by 5 mm of Hg every 3 hours until 25 mm of Hg. So you come from 45 mm of Hg up to 25 mm of Hg. Every 3 hours you have to do 5 mm of Hg. So until 25 mm of Hg is reached without bleeding, then keep the tube for 12 to 24 hours. But you can keep this prophylactically for 20 to 24 hours, but to avoid the rebleed. But you have to keep care that you have to deflate the balloon for 5 minutes every 6 hours. Every 6 hours you have to deflate the balloon for 5 minutes, so to avoid necrosis, because if there is continuous pressure, there will be necrosis. And you can see here that we have put this, and we have successfully engaged the esophageal balloon and the gastric balloon. So due to tamponade effect or pressure effect, we will stop the bleeding. Here you can see again And what are the possible complications associated with the blood transfusion? So complication may be broke down into immunological and non-immunological. So immunological acute hemolytic reaction can occur if it is not cross-matched. ABO incompatibility. Febrile non-hemolytic reaction can occur. Anaphylaxis can occur. Graft versus host disease can occur. Transfusion-related lung injury. TRALI. This can also occur. TRALI is more common with FFPs as compared to PEG cells or other products. So FFPs can cause TRALI more commonly. Non-immunological or congestive cardiac failure, if the patient is overload, hypothermia can occur, electrolyte imbalance can occur, especially hyperkalemia and hypocalcemia. So the transfused blood has chelating agents like calcium citrate. Citrate. These are the anticoagulants. So citrate will chelate the calcium in the body, so it can cause transient hypocalcemia. And hyperkalemia occurs from, like, these are the cells. So sometimes the cells, when they are old, they break down, so there will be hemolysis and there will be potassium release from the cells. Cells are the bags of potassium in a sea, so remember this. So there can be infection prions like hepatitis C, hepatitis B can be transfused through blood. There can be acidosis, acid-base disturbance. This can cause varices, acid-base disturbance as well. So what is massive transfusion? So massive transfusion is the transfusion of more than 50% of the patient blood volume in 12 to 24 hours. Replacement of more than 50% of the patient blood volume. Like if the patient who transfuse more than 50% of the patient blood volume in 12 to 24 hours, this will be called massive. Or you can define it as transfusion of greater than 4 units in 1 hour, or greater than or equal to 10 units within 24 hours with packed RBC, FFP and platelet in a balanced ratio of 1:1:1. So what are the complications of massive blood transfusion? Patient can go to overload, coagulopathy because of DIC, electrolyte imbalance, hyperkalemia, hypokalemia, and hypocalcemia. Usually hyperkalemia occurs. Hypothermia can occur, and acidosis or acid-base disturbance can occur. So this was all about the oesophageal varices, and we have covered this, and we can come back to this diagram. Yes. So this is the diagrammatic representation of the management. So if you receive acute varicose blood, first you have go for vasoactive drug therapy, pharmacological. So we have terlipressin, the first choice. The second choice is somatostatin or octreotide and beta blockers, and then give him antibiotics, conservative blood volume replacement, and rotational intubation if necessary, and then go for upper GI endoscopy. Upper GI endoscopy will show you the point which is bleeding, so you can go for endoscopic varicose ligation or bleeding sclerotherapy, or you can go for clipping. So if it's also not, if there is failure or still bleeding, then you can go for second attempt, and if it's still not working, then you can go for TIPS or shunt surgery, or you can go for Sangstecken Blackmore tube. Yes. So what are the portosystemic shunts in the body? So there are 6 places where portosystemic shunt occur. For example, the systemic and portal systems, they communicate with each other. So one is the lower end of the esophagus, where left gastric vein communicates with the azygous vein. So the other is superior rectal vein can communicate with the superior rectal vein communicate with the umbilical, not umbilical, superior rectal vein, where it is, yes, superior rectal vein communicate with the middle and inferior rectal vein, which is a branch of anterior iliac vein. Superior rectal vein is a branch of inferior mesenteric vein which drains into the portal vein, and middle and inferior rectal veins, these are the branches of internal iliac vein. So this, and then we have bare area of liver, which the hepatic and portal veins, and branches which communicate with the inferior phrenic veins. Okay, and then we have the patent ductus venosus. So left branch of portal vein, this can communicate with inferior vena cava directly. Okay, and retroperitoneal we have the colonic veins and the body wall veins. Systemic body wall, posterior or on laterally the body walls can communicate. And then we have the umbilical veins, so portal veins from ligamentum teres, and they can communicate with superior and inferior epigastric veins. So usually in we can see that in stenotic patient we have caput medusa. So this is actually the dilated umbilical periumbilical veins, which is communicating with the superior and inferior epigastric veins, and they usually transmit portal hypertension when there is portal hypertension. So that's all about esophagus, esophageal varices.